So I come with the ectopia lentis, the femto advantage, the back fixation techniques. Well, we have seen that Rexis, we have shown earlier, almost 3 surgeries have been shown how well it can be done, but it's not always hunky-dory. So these are things where there are problem and the Rexis goes to the periphery. So Rexis is unpredictable in subluxated cataracts. Let's be very clear about it. And capsulorhexis is definitely, if you get the right round center, that is an advantage, but if you can't get it, you can always have some problem. And capsular support devices, Dr. Biraj has shown us all this now. This becomes the standard CONE CTS here, remains the standard of care for this, and the tenoproline sutures that we've seen. And the long-term, stabilization is good with the present generation. But what is new? Let us come to that. Now, this I've just come to see the Rexis can be a tough job, as you can see. This case, the Rexis, you are trying to get it and match it, and many times see we put even a iris hook to keep it, but not always that we end up there, especially in this extreme subluxation. It really becomes difficult, and especially if we are doing the nuclear fragmentation, we have got an unstable bag, and getting that nucleus, chopping it sideways, definitely this flax has actually changed the paradigm how we do that Rexis. You can see that what we are doing is there. I'm positioning I can see where the lens is, and accordingly I change the Rexis position. This was a traumatic cataract. You can see the almost 90-degree subluxation. I've done a Rexis with the femto. It's so easily removed. After that, many times there are tilt. You may not be able to remove it, but then to correct that tilt, I do put viscoelastic by the side. And the first thing I do is do the anteroposterior support. I put the capsular hooks. The capsular hooks go and support it. My CTR goes in. Now CTR goes in and supports it in the periphery. So once I've done, see the emulsification becomes so easy. With this hard cataract, I don't have to, just have to keep my left hand pressure and the right hand just pull it out, get it emulsified. So no further increase in the back fluxation. There you get, I get it right, and then the last pieces are taken out, and it works very nice. Now, so once I've done that, there is vitreous there. So I remove the vitreous by a little bit of vitrectomy there. Once I've done that, I put that lens just like Dr. Siddhartha showed. In this case, I'm putting the lens in the sulcus, and the lens goes in the sulcus. No, in the back. This case, I'm putting the lens in the back. See, you can see the lens. Since the subluxation was not much, the lens goes, the multi-piece lens goes in the back, and it has maintained its the central part. And so I go next to the next case. As you can see, this well-round central pupil, and it has continued. Now, this is another case where you can see this. I have moved the Rexis to the periphery, so I've got the round globular lens that is there. Once that is there, it's the femto goes in. See, there is a tilt there, and so with that tilt, I'm trying to get that Rexis cleared up. This is a soft cataract. As I'm trying to clear that Rexis and tear that Rexis, because of the tilt, you cannot get the total marks, but then it corrects. Normally, the machine corrects up to 15-degree tilt, but if it is more than that, many times you can miss it. So I'm continuing in the same process again, doing the visco section, putting the hooks and the CTR. Once that CTR is there, you can see the CTR goes in, and this is the CTR goes in. This is a soft cataract, so I don't have to struggle much to remove that. Once I've removed that, so I'm putting this lens, I'm putting in the sulcus. As you see, this was almost more than 180-degree subluxation. Later on, it was looking like 270-degree subluxation. I just put the lens in the sulcus and then capture it in the back. Now, this patient is almost on the follow-up for almost 8 months now. And I think I've done it just after the last time the lockdown had opened, the month of July, August. So there, the lens is there, well centered. Now, this is again another case of Marfan's syndrome. Now, this is a progressive type of zonal dehiscence. So what I do is the same way. I just go and get the capsular hooks, and this is a soft cataract. So all I need to is just to suck those material by bimanual IA, and a single piece lens goes in the bag. And what I'm trying to do is modify my way of, instead of putting suture, I'm putting a iris hook there with the CT segment, and there I can tuck it right inside the sclera. Once I've tucked it, I've got it right in the position, and this patient is almost on the follow-up for almost more than 18 months now, and this is doing absolutely fine. Well, we've seen nice cases, but it is not always hanky-dory. And this case, as you can see, the femto may not be always useful, as this case, see, as I'm trying to do it in the periphery, there has got my rexis there. Once I've got, see, it's an incomplete rexis. So all I have to do is hold it here by the rexis forceps. And once that is done, see, I have to hold it, and then the rexis goes a little bit to the periphery, but somehow I did manage this case. I just wanted to show that always it may not be possible if the tilt is more than 180 degree. In this case, it was more than that. And coming over the newer capsular supports, now you see I've done it. If you look at it, this is one, this is one of our earlier co-instructor, Dr. Jacob. She has got it out, and this you can see, you can just pull it and tuck it the way. This is the idea that I've used for my last case. And so there are a lot of papers to support it. Management of cataract acid. Dr. Chi is here. She has got a lot of work on that has shown. And there's a study by Dr. Tithial et al. Was shown that the femtosecond laser pre-treatment allows a closed chamber creation of corneal incision and capsulotomy. And this vitreous AC did not hamper femtosecond laser, because we have got vitreous in AC in traumatic cataract, we can still do it. And this is again another study. We saw the application of femto laser assisted technology enhances surgical safety and effectiveness of subluxation lens and promotes maximum recovery of the patient. So thank you. This is a new armamentarium in our hand, and if you can use it in the selected cases where the tilt is not so much, it definitely gives good result. Thank you.